Let me go ahead and introduce our first speaker. Dr. Saumya Jamuar is the director of the Center for Precision Health and Pediatrics in Singapore. He's also the chair of the chapter of Genomic Medicine, AMS, and co-chair of the Genetic and Genomic Testing and Research Review Group, BAC. He previously served as the director of the Sing Health Duke NUS Institute of Precision Medicine and inaugural head of the Sing Health Duke NUS Genomic Medicine Center. After graduating from NUS, Saumya completed his pediatric training at Sing Health, followed by his clinical genetics fellowship at Harvard Medical School. He's actively involved in research, has published in top-tier journals, and as you may have guessed, Saumya's clinical work played a critical role in the groundbreaking study on UGDH-related disorders, which is why many of us now call it Jamuar syndrome. Saumya has proven to be an extremely knowledgeable and helpful advisor to us at the UGDH Foundation, and something I especially appreciate is he seems to truly have the soul of a clinician who wants to see his patients flourish. So let's hear from Saumya now.
Thank you, Rebecca, for the very kind introduction, and a very good morning, afternoon, evening to everyone who's joined from all over the globe. I think it's 13 countries, but I think it's probably all six except Antarctica that's covered. So I'm really happy and pleased to be the first speaker. Just to set the tone of what's going to come, because I, in a way, am the past, and what the rest of the speakers are going to be speaking is what the future is for Jamuar syndrome or UGDH-related disorder. I'm just going to pull up my slides, and hopefully that's coming through. All right, Rebecca, is that okay? Slides coming?
Looks good.
Perfect. Thank you so much. Okay. So I think, Rebecca, it's hard to go after you because you've actually articulated this challenge, this issue so well. And I'm just going to repeat it just in the way I do as a clinician, but it can never match the way you have articulated it. So bear with me. I'm a clinical geneticist. I see patients with genetic disorders, and in the past, just the nomenclature, it being rare, meant that these were disorders that affected very few people. But as our understanding has improved, we realized that actually it's although they're individually rare, cumulatively they affect about 5 to 7% of the population. And the current estimates are between 350 to 400 million people in the world who have a rare genetic disease. A massive fraction of them remain trapped in this, what we call the undiagnosed void, and are invisible to modern medicine. So as a clinician and as a scientist, the question is, how do you define what is the void? And the void is individuals who have these symptoms that are not clearly defined in any existing clinical categories. And so from that perspective, the mission is, as a global community, to identify the genetic etiology to provide answers to families living with rare and undiagnosed diseases. This is something that many of you in the audience are familiar with. The diagnostic odyssey, diagnostic labyrinth, takes 5 to 7 years on average. It going through multiple specialists, multiple investigations, and often a clinical jeopardy where sometimes individuals get misdiagnosed before they get the correct diagnosis. The challenge with being undiagnosed is that it's a missing key. And I think many of you would have faced this before 2020 when we published the paper. Without the diagnosis, there was no formal way to code the child's medical condition. And without that formal diagnosis code, you don't have access to may not have access to insurance, may not get the full school support, and you may not have access to the expert communities. So the diagnosis is the key that actually opens many doors for families. And besides this burden of proof and to prove that child does have a rare genetic disorder, there's a psychological toll as well as social isolation, because you don't know who else you can reach out to. So this is where we segue into where this journey began. And I was looking in the participants. I didn't see them yet, but hopefully they will join. This is the story of these two young siblings, Sienna and Atira. Atira is at the back, Sienna in front, the parents. This was during COVID, so everyone was masked up. We were trying to maintain some social distancing in the clinic. And what they presented with was developmental delay and seizure, something that I think many in the audience are familiar with because that's how their child would have presented as well. They had multiple extensive investigations. This was back in 2015 when we first saw them. And there was no diagnosis. At that point in Singapore, I was leading the Singapore Undiagnosed Disease Program. And we called the program Bridges because it was a metaphor for bringing these research innovations that were happening across the globe to improve the diagnosis of these genetic diseases in Singapore. And it was a bridge between the patients and the research institutes. So we got all the clinical centers in Singapore to come together. And one of the main sub-aims of this was to directly benefit patients and improve their health outcomes. So the siblings were enrolled into the Bridges program. And when we did whole exome sequencing, we identified a specific variant in the gene, which you all are very familiar with now, called UDP glucose 6 dehydrogenase. Back in 2015, we didn't know much about this gene, except that it was involved in the formation of what we call proteoglycans. And again, as you've all learned, proteoglycans are part of what we call the extracellular matrix, and that is a scaffold that allows the neurons to link together and form the structure of the brain. And so you can imagine if the scaffold is missing, the neurons are not connecting to each other. And that leads to disruption, and that leads to the symptoms that we see in individuals with Jamuar syndrome. So UGDH was a precursor for the proteoglycan synthesis in the brain. Again, as Rebecca said, when we started, it was one family. But again, because of the community that had been built around this, we reached out and I quickly identified initially 4 and then subsequently 18 other families who had similar symptoms and variants in UGDH. And then we then having that confidence that yes, this might be a true link between a gene and a disease, we then took cell lines from blood samples from some of these individuals, brought them to the lab to develop what we call patient-derived cells to create these 2D and 3-dimensional cellular models. These models allowed us to observe how the variant affects brain development. So in a 2-dimensional setting, we looked at how the proteoglycan marker, hyaluronic acid, was being produced. And again, as you can see on the right, which is A82T, which is homozygous for A82T, there was reduced production of hyaluronic acid as well as NADH compared to what we call wild type, which is a healthy individual. And in the middle is the mom who's a carrier. So it's reduced, but it's only halfway between the healthy control and the patient. We then looked at UGDH in the form of 3D organoids, or what we call mini brains. And on top 2 are unaffected individuals, and the bottom 3 are individuals with UGDH-related disorder. And what we saw was there was disorganization, the brain volume was reduced. And this is where we kind of convinced ourselves and then the scientific community that UGDH indeed was crucial for synthesis of brain's extracellular matrix, that variants in this gene do disrupt this process, affecting brain development, which potentially explains the severe neurological symptoms. and hence validates our findings. And this is when we publish and establish the new disease entity. So the next question is why, what does this do? And while the syndrome was named, and you know, I'm humbled to have the syndrome named after me, it's a recognition of the team's work. So it's not my work. It's actually the whole team that did it. But more importantly, I think its real significance is for the families, because now there's a name, and that name allows to build a shared community and potentially a path forward. And it transforms a mystery into a known condition. So as Rebecca said, there are 4 organizations. I've highlighted 2 of them that I've worked with, the UGDH Foundation in the US and UGDH Italia. And that's a photograph from one of the groups. And what that allows the community to do is move to the next frontier, because the diagnosis is just the end of one journey, but then the beginning of the next. And the so what question changes to how do we move from knowing the cause to finding a cure? What we have done successfully is we have transitioned from the clinical observation of this unique clinical profile with the genomic data to some mechanistic research, but there's still a lot to be learned. And I'm glad to see Professor Manuela Botani in the audience, because she's leading some of that effort, and be really excited to hear what she has done in the past few years through these projects that were funded. So just ending off, I think this is not an individual's journey. It's not a clinician's journey. It's not the patient's journey. It's not one family's journey, but it's a power of collaboration. And this is where we need to work together for the children. Because rare diseases are complex, we need a multidisciplinary approach, but it's not working within our region, within our country, within our city, but needing international partners to pool knowledge and resources. More importantly, it's not just one aspect of the team. It's a team that comprises of clinicians, genetic counselors, bioinformaticians, allied health professionals, but more importantly, families. And this is where, you know, I give credit to Rebecca and the board for what they've done at the UGDH Foundation, because that's a testament to the power of what can be done. Rather than, as Rebecca said, rather than waiting for research to happen, UGDH Foundation is shaping that research. And I'm really glad to be at this symposium, very excited to hear what's going to come next. And with that, I will hand the time back to Rebecca.
Thank you, Saumya. So we're going to have, we've got a good bit of time for discussion and questions. Feel free to raise your hand if the Q&A is not working for you, and you'd rather type it, put it in the chat. One question I had was, and other speakers too are welcome to pipe in to this as well. UGDH does not have its own ICD-10 code. It is part of an umbrella code. How useful do you think it would be for it to have its own?
Yeah. So I think, Rebecca, that's a huge problem in the field of rare genetic diseases. So not just UGDH, but most of the rare genetic diseases, especially the ultra rare genetic diseases, where you have less than 1,000 patients worldwide, do not have an ICD-10 code yet. And that is actually a big problem, because when it comes to the regulators, the funders, the governments, and you want to showcase the burden of the problem, most of these agencies, what they do is they look at the ICD code and say, look, this is what we have, and this is what the cost associated with care of that ICD code is. But when you don't have that ICD code, you can't quantify. So this is the hidden cost. And some people have estimated that the cost of looking after children with the inpatient cost of looking after children with pediatric rare genetic diseases is 2/3 of the entire cost of that the hospital spends on care of patients. So that's double what they spend on diabetes, on cardiac disease, and other stuff in the pediatric setting. But the problem is it doesn't get quantified because we don't have an ICD code. Again, that's something that is being resolved at multiple levels. And one of the levels is that from a coding perspective, there's this thing called ORFA codes, which is being implemented in many institutions so that we can actually accurately capture the true burden of a specific rare genetic disorder, including the UGDH. NOMED, which is the other disease classification system, is actually slightly better. And that's being adopted by some of the non-American healthcare systems, which again helps to capture that. So personally, I think, yes, it would help to be able to code. What I'm not sure is whether it should be ICD or whether it should be something else. And I think the move has been towards that something else first, and then hopefully convince ICD to include that.
Dr. Jamar, first, thank you for that great talk. We have a question from the chat from Kira Sabanova. So she asks, what is used to control the seizures in UGDH syndrome?
Yeah. So I'm not a neurologist, but again, from what we know is that the spectrum of seizures can be fairly severe in the cases that were initially reported, where they presented with severe infantile onset epileptic encephalopathy, to actually fairly intermittent seizures that happen either with fever or with illness and stuff. So again, in terms of the anti-epileptics, there hasn't been any specific anti-epileptic that works better. I think in terms of the conversations with different families, many of them have been on sodium valproate, some of them in Keppra. I think some of them have tried ketogenic diet as well. So as far as I'm aware, there isn't any specific, but I'm happy for anyone else to chime in as well, especially if there's a neurologist who can chime in if there's any specific preferred anti-epileptic. But my sense is that it's the standard management in terms of trying a anti-epileptic and then moving up, making sure that we avoid toxicity from the anti-epileptic, but have appropriate seizure control.
And later this morning, we're going to have a presentation about the surveys that are available for our patient groups to take. And one of them is a seizure survey. And it's detailed. It asks for medications. It asks for if we think it helped. And my understanding is right now we have not had enough patient families respond to make it wise to kind of share those findings. But that's another reason that we would love more families to participate in this opportunity, because eventually we may be able to kind of add to that understanding of helpful anti-epileptic approaches.
Dr. Jamar, I'll ask a question. For kids who had their sequencing done prior to 2020, do you think there are some out there that still haven't been diagnosed, and what would be the best way for them to get a diagnosis?
Yeah, great question. And this is something that we have learned as well, is that periodic re-examination of an undiagnosed patient or periodic re-examination of the genomic data of a previously undiagnosed patient is very important. And usually we try to do that every 6 to 12 monthly to kind of, because the pace of discovery is such that we are discovering 3 new diseases every week. And so in a year, there's at least 100 to 150 new diseases that have been discovered. So anyone who's been sequenced before 2020, I think and they haven't been reanalyzed, then they should be. One of the challenges was that the other challenges was in terms of testing. a lot of patients who have epileptic encephalopathy get tested using panels. And most of the panels are focused on the dominant conditions, like the sodium channel and the calcium channel and the potassium channel. But as we know, UGDH is a recessive disease, and that doesn't get picked up. And that's something that Lena is going to cover in her talk. But that's something that's important to know because the risk of recurrence is different for the two, for those who have the channelopathy versus those who have UGDH. And I think I had a conversation with some of the labs to say, can you please include UGDH in your epilepsy panel? And they were reluctant to add because they said, look, we've got too many genes to add. We don't want to add at this point of time. I think what's important is that while the families here have been diagnosed, there are other families who have kids with epileptic encephalopathy who had a panel and they think they are negative. They may not have been tested for UGH, and that's something that needs to be. I also just noticed that Bruno has joined, so I don't want to put him on the spot, but if Bruno, if you are able to speak about your, any comments that you may have about, because you were pivotal in this discovery as well.
Yeah, I can only paraphrase your comment. We have to reanalyze. I think what we are needing here for UGDH is probably a saturating mutagenesis of all the codons of UGDH so that we know which novel alleles are potentially deleterious. So we have only a few of them, but we would really need to sequentially mutate, do sort of an alanine scan, and have a functional readout for all possible type of mutations. So then when we discover them in the clinic, we say, oh yes, this one has been tested and is functionally deleterious, and we don't have that. Thank you.
Thanks, Bruno. Thank you. Yeah. And again, that's a great idea and another reason to raise funds to support the research.
We have a couple of questions about phenotypic characteristics of patients. So one question about, are there any known cardiac health issues in the known patients? And then are there any patients who show some developmental ability, or are they all bedridden and unable to care for themselves?
Yeah. So in terms of cardiac, again, as far as I'm aware, and there isn't. The only thing that does come up is this pulmonary hypertension that may be related to episodes of pneumonias, aspiration pneumonia and stuff, but that's something that wasn't reported in the initial paper, and then that came up on subsequent conversations, but not from a structural heart perspective. In terms of the developmental phenotype, while majority of the patients indeed have significant developmental delay, the patients that I'm following up in Singapore, they are actually progressing. So the oldest now is in the 20s, and the younger one is mid-teenage. And the younger one is progressing better is progressing faster than the older one. She's actually verbalizing. She can say few words. They're both ambulatory, and they have some, they are able to help with some of the activities of daily living. So again, there is a spectrum. And that's something that we need to understand better, whether there is a genotype-phenotype correlation of some sort.
All right, we have another question in the chat. Two questions. So this is from Dr. Simpson. Are patients with UGDH variants more or less responsive than other developmental epileptic encephalopathy patients to ketogenic or other lipid supplemented dietary strategies to manage seizures?
I don't think we have enough data to support that or not. But My sense is that there shouldn't be in terms of the metabolic pathway. Melanie, I think that's a great question, and that's something that I think we had wanted to study, and it would be good to understand, because if ketogenic diet does help, and it should, there's no reason why it shouldn't. The question is, does it preferentially benefit individuals with UGDH-related disorder or not? So at this point of time, I don't think we have that data yet, and that's something that needs to be generated.
Another question, are there patients with compound heterozygous variants where the variants are inherited from both mom and dad, but located in different segments of the gene? And how can one participate in your studies?
Yeah, so again, while some families did have what we call a homozygous, where it was the same variant inherited from the mom and the dad, many families actually were compound heterozygous, where the dad and the mom had variants in different segments of the gene, both affected or disrupted the function of the enzyme. And this is something that Dr. Melanie Simpson is working very hard on, where she's building a functional model to test these variants and test whether the variants are pathogenic or not. So if an individual has epileptic encephalopathy or features of Jamuar syndrome, has had exome or some testing done, and has been identified to have variants of uncertain significance in UGDH, then do reach out to Rebecca, and then so then Lena and I would review the variants. Primarily, Lena reviews it, and I usually agree with her classification. And then once we feel that that's appropriate, we then ask for Melanie to help to functionalize those variants. So if there are any families in the chat, in the audience today who have a variant of uncertain significance, please do reach out, and we'll be happy to see how we can help to functionalize that variant. The second study that I think Rebecca was alluding to was the natural history study, which we are trying to understand the answers, some of the questions that you are asking. Which anti-epileptic works better? What is the developmental trajectory for these individuals? So again, those are active, ongoing studies, and if you haven't already participated and are interested to participate, please do reach out. And I think Rebecca can share that, connect you with the appropriate investigators.